Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds for this November 28th, I believe. This morning, I have the distinct pleasure to be able to introduce a friend, colleague, and very accomplished scientist, Dr. Vanessa Ferreira. Vanessa began her career at MIT. She did her undergraduate at MIT, went on to medical school at UBC, did her internal medicine at UBC, and came to Calgary for cardiology. Following that, we weren't able to keep her in Canada. She headed off to Oxford to do a PhD with Stefan Neubauer, who is a cardiac MRI expert at Oxford. Vanessa continued to be extremely successful there and was hired on by that group, and ultimately has moved on to become the Deputy Clinical Director of the Oxford Center of Cardiovascular Magnetic Resonance Research. She is also currently on the executive of the Society for Cardiovascular Magnetic Resonance. She's the deputy treasurer at the moment and will be moving up into the presidency in a few years' time. We're talking about where she's going to host her meeting. Anyway, her scientific record is very impressive. She specializes in T1 mapping, and she's going to talk about her Schmally sequences and T1 mapping today. So, Vanessa, welcome to Calgary, and I look forward to your talk.
Andrew, thank you for the kind introduction. Is this okay? Can you hear me with the microphone being here? Okay, all right, great. And hi, everyone. My name is Vanessa Ferreira, and I'm so happy to be here in Calgary again. I see many friendly faces, and I look forward to getting to know some of you whom I haven't met yet. So I will share with you how we may use CMR parametric mapping in the investigation of many cardiovascular diseases, and I'll present many of my research done over the past 15 years and some of the research directions in the field of CMR. So I had 3 wonderful years here in Calgary. I can't remember which cath lab this is, but it's one of the maybe cath lab E, I can't remember. And so this is me doing a diagnostic angiogram, and that's one of the cath lab nurses. We were still doing femoral approaches back then. That was routine. And so here, what happened, at the end of fellowship was I decided to subspecialize in CMR, and together with Matthias Friedrich, who was the director of the Stevenson Center at the time, we co-developed a plan to go to Oxford to do a PhD there for me. And we were successful in securing a clinical fellowship through the Alberta Heritage Foundation, now Alberta Innovates. And so this was fantastic news, and it covered a stipend for 4 years. And, Dr. Kavanagh here, she was my research mentor from the very beginning. And so, there are a number of key individuals, who helped me with this. And I remember Todd Anderson spending, a lot of time on this application, with me as well. So thank you all, for this. Now, this covered the stipend, and I was fortunate enough to win a Clarendon scholarship from Oxford, which covered the actual tuition and college fees at international student rate. So that was a relief. And so then this allowed me to take up the offer, and I started my PhD in 2008. And this is one of the constituent colleges in Oxford. It's Merton College, and you have to belong to a college to study for a degree there. You may recognize the background from perhaps some of the Inspector Morse, Inspector Lewis TV series. Many of them, were filmed here. It's beautiful. And so now, broadly, my research focus is to investigate acute and chronic pathophysiologic processes that lead to cardiac dysfunction and heart failure, and how these may be detected using non-invasive MRI biomarkers as a basis to develop new tools for diagnosis, early intervention, and monitoring therapy. And specifically, myocardial edema, ischemia, and fibrosis occur in a variety of common cardiac conditions, and these processes are detectable using cardiac MRI, or what we call CMR, especially using quantitative, high-resolution, pixel-wise parametric mapping. So why do we need parametric mapping? Because it gives you objective tissue characterization in a quantitative manner. So this is just a single short axis slice through the heart. It's the same slice. And all I've done here is alter one MRI parameter that's called the inversion time. And as you can see, just by altering that one parameter, I can change the tissue contrast and the way it appears. This is good for visual, assessment of, things like fat and, edema. But let's say if you put me into the scanner, you take me out and you put me back in, and you get these same images, they're not directly comparable with each other. And so, and it means that you cannot sort of longitudinally track somebody's disease progress quantitatively, and you cannot compare between patients in a directly quantitative manner. And this is different with quantitative mapping. So this below here is a T1 map in grayscale, and I've put a cursor in 1 pixel in the septum over there, and that 1 pixel will have a T1 value. And here you can quantify what that T1 value is. It is a numerical number. It's a quantitative MR property of that pixel. And if you do it for every single pixel in the point in the field of view, you would then generate what we call a parametric map. You can do this for T1 relaxation time or T2 relaxation time. And every single pixel here has a quantitative T1 value that will allow you to compare within individual and between patients in a quantitative manner, as long as you keep the method stable. So you don't need to know this equation. I'm just trying to show you where T1 sits. This is a T1 recovery curve. And this mathematical formula describes this recovery process. And T1 is this decay constant that sits right here that governs this process. And so the main idea is that every tissue, for example, myocardium, will have a normal range of T1 values. For example, the myocardium has a T1 value of around 960 milliseconds. It will have a standard deviation, but you have to specify what field strength magnet you're using and what particular T1 mapping method you're using, because these technical parameters will change what a normal value would be. So these are important things to say when you describe something. And if you deviate from that normal range, it may be disease states. So I know that there may be early career trainees here, so I'll start with the basics. So cardiac MRI, you need a strong external magnetic field, and that's our scanner. The scanner is just a big magnet. It's got a north and south pole, and CMR uses the same basic principles as other MRI techniques with the addition of ECG gating, because the heart beats and it moves, and we want to image when the heart is most still. So for the scanner to know that, it needs to know what the ECG and when systole and diastole is, and we usually would do diastolic readout, for the images. And most clinical CMR will use the proton nuclei for contrast generation because it's very abundant in human tissue, but you can use other nuclei like 31 phosphorus for spectroscopy or carbon-13 for metabolic imaging. But clinically, we usually use protons. Of course, we don't use radiation. We're not ultrasound. So the way we generate images is by using a radio frequency pulse or RF pulses and RF coils. These are similar to, let's say, microwaves. And by disturbing the patient's own proton nuclei, we can, absorb and then reemit that energy. And these things can be measured and translated into images using Fourier transform and without using ionizing radiation. So here are the basic setup. So here is a patient. The magnet is your north and south pole. The patient is lying on a set of coils in there, and we're putting surface coils on top of the chest. We're imaging the heart. And inside the board, there will be body coils that we can't see. They're gradient coils. And of course, we have to put stickers on and hook the patient onto an ECG monitor so the scanner knows what the heart rate is doing. And so now when you roll the patient into the scanner, interesting things happen. And so let's pretend these are the protons in the patient's body tissue. Most of them will align to the external magnetic field in one way. Some of them will align in the opposite way. So let's just take this as a simple illustration. Now, they're not static, they spin on their own. And so they're processing on their own. And what we're going to do right now is to apply an RF pulse, a radio frequency, so wiggly lines in the background. We're going to tip the magnetic moment to a different plane. So here we're just going to do it to 90 degrees. And what we're going to do is release that RF pulse. So that disappears, and watch what happens to the protons. Some of them will realign really quickly to the external magnetic field, things like fat, but others will realign more slowly, things like water, CSF. And so in this way, different tissue types, and depending on their surrounding chemical milieu, will realign at different rates. And this is how we generate image contrast between tissues. And so this is just a summary of the vector representation of the total combined magnetization of the spins that I just told you. So we flipped it to the XY plane, and then eventually the magnetic moments will go back to their thermal equilibrium. And this is T1 relaxation time, or longitudinal or spin lattice relaxation time. This is very, very simplified, obviously. Now, at the same time, when that is going on, there will also be T2 relaxation going on, realigning to its thermal equilibrium. So each tissue will have a corresponding T1 and T2 relaxation time. And these things can be measured using MRI scans. And so these are quantitative properties. So CMR has undergone a number of significant developments in its maturation as a non-invasive imaging technique, as we can see here. So after Cine imaging, late gadolinium enhancement, and stress perfusion imaging, parametric mapping is widely regarded as the fourth era of CMR. And so the first major success in the application of mapping techniques was the use of T2 star relaxometry for detecting myocardial iron by the Royal Brompton Group in the UK. And this ability to detect myocardial iron and then subsequently treating the patients, with chelation therapy led to a very significant reduction in cardiac deaths by 71% in thalassemia patients. And so this is one of the holy grails of imaging. We want to be able to not only produce beautiful images, but more importantly, it needs to change clinical outcomes for the patient for the better. And so I'll give a brief overview for the next generation of parametric mapping techniques. So these are the T1, T2, ECV, what we've achieved so far. And so in 2018, the ESC has named CMR mapping as one of 6 most innovative imaging methods to assess the heart, in especially heart failure patients, beyond what late gadolinium imaging can offer. And so T1, T2 mapping, they are now increasingly used in a clinical service for advanced myocardial tissue characterization. So what's the advantage of mapping? So in general, parametric mapping have several properties of a good diagnostic test, including a narrow normal range. They are very reproducible, and importantly, they are sensitive to detecting changes in disease. So let's start with T1 mapping. This is a T1 map on your right. We haven't injected any contrast. So it's a quantitative MRI technique. It measures T1 relaxation time of tissues on a pixel by pixel basis. So on this T1 map here, each pixel has a T1 value of the underlying tissue, and we can code these numerical values on a color scale such that tissues with short T1 values like fat will appear blue, intermediate T1 values will appear green, and long T1 values like blood appear red. So in this way, we can begin to visualize different tissue types based on their quantitative MR properties without the need for contrast agents. And each tissue type has a specific normal range at a particular field strength. So normal T1 values of the myocardium is like our body temperature. So deviation either too low or too high, it may indicate disease. So the commonly available cardiac T1 mapping techniques, or sequences as we call them, they have good metrological properties, like the Schmolle technique shown here. We developed this in Oxford. It has a tight normal range. You can see that the standard deviation is 25 milliseconds as compared to the average value is about 2%. So it's got very good reproducibility with a 2% range across multiple centers. And there are other T1 mapping techniques available. So this is Molle T1 mapping techniques, and it also shows a tight normal range when you keep a method stable and consistent between centers. So T1 mapping is very sensitive to detecting increased free water content in tissues, like in many disease states. This is one of my early studies validating T1 mapping for detecting acute myocardial edema. And these are mainly Takotsubo patients with a lot of swelling, but no infarction. And here, what we've shown is there's superiority for the T1 mapping, the green curve here, over the traditional T2 weighted images in detecting edema, probably because it is a directly quantitative technique with certain technical advantages. So near that time, the NIH group also showed that in animal models of acute myocardial infarction, both T1 and T2 mapping can be used to detect the area at risk using fluorescent microspheres and histopathology as a gold standard. So clinically, T1 mapping is very sensitive to the increased water content in tissue. So it can be used to detect the area at risk in acute myocardial infarction. And so here, T1 maps, when it goes red, it means that there's a lot of water and probably a lot of swelling, edema, inflammation in the acute MI. And, it detects, especially in non-STEMI patients, it detects a much larger area of injury compared to the late GAD and the traditional T2 weighted edema imaging techniques. We can use it for acute myocarditis. And so here we showed that the diagnostic performance of T1 mapping, which is the red curve, is equivalent to late GAD imaging, the blue curve, except of course T1 mapping does not require gadolinium contrast agents. And further, I've also discovered that the numerical signal within each pixel can reveal the typical patterns that we see in late GAD imaging, as well as detect areas of myocardial abnormalities that are not shown on late GAD. You can see a case of severe myocarditis here in the top row with very impressive late GAD findings in the far right. And the T1 maps here show that there's diffuse edema, even in the areas without late gadolinium enhancement. And with increasing thresholding techniques, you can also see the predominantly non-ischemic mid-wall and subepicardial patterns that are hidden within. These other two cases are mild to moderate myocarditis, again showing that the T1 map can detect changes that are not so obvious on the late GAD images. So this would set the stage for the next step in our program, which was to render CMR gadolinium-free in the future. So T1 mapping is also great for detecting myocarditis in association with other systemic diseases. For example, this is the first paper on the use of CMR and mapping to systematically characterize subclinical catecholamine myocarditis in patients with pheochromocytoma. And we've also applied the technique to demonstrate subclinical myocardial involvement in other systemic diseases, such as rheumatoid arthritis, lupus erythematosus, and systemic sclerosis. So far, I've shown you that acute myocardial edema and inflammation can make the T1 values go really high. And another cardiac disease that can make the T1 values go very high is cardiac amyloidosis. So these are very typical images of severe cardiac amyloidosis. As you can see, the cine images over here showed a very hypertrophied left ventricle. And the late GAD image on the right shows the typical diffuse circumferential enhancement with very dark blood pool. And the native T1 map in the middle shows diffusely high T1 values. On the other end of the spectrum is Anderson-Fabry disease, which tends to have very low T1 values. So Anderson-Fabry disease, you may recall, is an X-linked disorder of alpha-galactosidase deficiency, and this results in accumulation of sphingolipids in the heart and other organs. On CMR, we see a left ventricular hypertrophy phenotype, and on late GAD, it's got this characteristic broad midwall band in the basal infralateral wall. And on pathology, there is accumulation of sphingolipids in the heart, but this area of late gadolinium enhancement corresponds to an area of dense collagen fiber and fibrosis. And we can see these very clearly on the native T1 map in the middle. So on the late GAD image on the right, we see this kind of fuzziness in the hypertrophied septum, and you're never really quite sure whether this is real or whether this is due to image quality. And you also see this broad midwall band that we talked about before. And in the T1 map in the middle, you can easily see two populations of abnormal tissues within the myocardium. So one with very low T1 values, that's coded as blue, and the area of high T1 that corresponds to the area of scarring. So this T1 mapping is not only a nice, pretty picture, but it offers additional useful information beyond the grayscale late GAD imaging. The other disease that gives you very low T1 values is iron overload. So T1 mapping has been shown to be quite sensitive to iron content in tissues because iron is paramagnetic and will lower T1 values. So this is an example showing that mild iron overload will give you lower T2 star and T1 values. And as this becomes more and more severe, the T2 star and T1 values also become progressively lower and lower. So T1 mapping is also useful in other types of cardiomyopathies. This study from our group again shows that in both dilated and hypertrophic cardiomyopathy, even in the segments that have normal wall thickness and without late gadolinium enhancement, the T1 values are still abnormal, thus again offering something beyond what the normal CMR techniques can detect. So moving on to extracellular volume or ECV quantification. So there's a lot of interest to quantify the ECV in a variety of cardiac diseases, especially in heart failure and cardiomyopathies, because it can act as a surrogate marker for myocardial interstitial fibrosis. Now, I won't go into the theory and assumptions of measuring ECV using T1 mapping and gadolinium contrast agents, but practically what you would need is to fill in the 5 variables in this equation. So you need a pre-contrast T1 map to give you the pre-contrast T1 values of the myocardium and the LV blood, a post-contrast T1 map to give you the post-contrast T1 value of the myocardium and the LV blood, and then finally the hematocrit of the patient, which you would get from a blood sample. And when you have plugged in these 5 variables, you can estimate the ECV. And these are examples of beautiful ECV maps of the heart in different diseases, and various studies have shown that an expanded ECV carries a poorer prognosis, especially in heart failure patients. Going on to T2 mapping. So T2 mapping works along very similar principles as T1 mapping in that it measures a quantitative MR property in tissues. Like T1 mapping, tissues have normal T2 values, and T2 tends to go up when there's increased free water content in tissue. So it's quite useful in detecting myocardial edema and inflammation in a variety of cardiac pathologies, including myocarditis, acute myocardial infarction, and Takotsubo cardiomyopathy. And most of you may know that the original Lake Louise criteria in 2009 was written here in Calgary at Lake Louise when Matthias Friedrich led the effort. It describes how we can use CMR to diagnose myocarditis. And due to the promising clinical utility of mapping techniques, Matthias invited me to lead this update to include T1 and T2 mapping into the CMR criteria. And we expect that these quantitative methods will replace conventional weighted imaging methods with greater sensitivity and diagnostic performance in the non-invasive evaluation of myocardial inflammation. So this is a patient with very severe myocarditis, showing extensive non-ischemic late gad patterns here in the top right, very high T2 signals globally in the T2 weighted imaging and T2 mapping, very high native T1 values. You can see the pericardial effusion with very, very high T1 values, and a very expanded ECV because mainly of the edema. So this is the first section of the talk, about mapping, and I'm going to show you some pictures. Hello, Sarah. Hello, please come on. I think there are some seats here. So people maybe can come in. And okay, right. So this is the Oxford Examination Schools on High Street in Oxford. You have to hand in your thesis here by the deadline. And so this is me handing in my thesis, and here it is, T1 mapping as a novel technique for myocardial tissue characterization using CMR from method development to clinical validation and application. And so this was graduation. So the Oxford PhDs have this color of their academic gown. It's scarlet and navy blue. And this is the warden of Merton College handing me the degree. And this is lunch after the ceremony. Okay, so moving on to the next stage in our research program. So continuing to innovate new approaches for CMR imaging, we began to work with computer scientists and machine learning experts, such as Dr. Chang Zhang, together with Professor Stefan Piechnik with his expertise in biomedical imaging. Essentially, we can generate virtual late gadolinium enhancement using only pre-contrast images, such as Cine and T1 maps. So this is how it works, and we call it virtual native enhancement, or VNE. So first, we would acquire pre-contrast images such as Cine imaging, pretty routine, and native T1 maps like this color map. It doesn't just contain the pixel-wise color map, but underlying all of that, it has raw images of different T1 weighting. And then we feed them into the deep learning VNE generator. And the generator would then use multiple streams of neural networks to produce image feature maps. Then all feature maps are input into a further neural network block to fuse the information from these multiple images to finally produce a VNE image here that you see. And of course, to validate this, we would have acquired real late GAD images from these patients. So these are all hypertrophic cardiomyopathy patients in this initial iteration. And so the model was trained using a generative adversarial network to encourage the generator to produce images that look like the real late GAD. And so these are examples of conventional late GAD in the top row and the virtual VNE in the bottom row. So here, these two show suboptimal nulling of normal myocardium, and the VNE is showing you what it really should look like. And these here in the middle, it shows motion and ghosting in the real late GAD images, and the virtual late GAD, is much more stable. And finally, here on the right is noise. There's a lot of noise and blurring in the real late GAD. And again, the virtual late GAD shows much better image quality. And so we had 4 independent operators score the quality of the real late GAD and the virtual late GAD, and they were blinded as to which was which. So overall, VNE achieved significantly better quality than late GAD. But what about the quantification of the actual late GAD lesions? So VNE also correlated strongly with conventional late GAD in quantifying the hyperintensity to intermediate intensity lesions that you see in HOCM using various image analysis thresholds for comparisons. And we then moved on to develop VNE for other scar imaging, for example, chronic myocardial infarction and viability testing. So in our results, here is a patient who has a chronic MI downstream from the LAD territory. These are 3 short axis images, and the VNE revealed the infarction on all slices in high agreement with late GAD. And these are corresponding transmurality plots on the right, where red, sorry, something popped up on my screen. Okay, never mind. Okay, right. Transmurality plots on the right, where red indicates a low viability and green indicates likely viability using the 50% thickness cutoff between the 2 shades of color. And we see a clear transmural LAD infarction on both the VNE and the late GAD. And what about infarctions in multiple territories? So here's another patient where VNE revealed 2 infarctions, one in the septum and one in the inferior wall, confirmed on the late GAD images. And again, we see a high agreement between the 2 methods on the transmurality plots. So on quantitative analysis in the testing data set, VNE correlated strongly with late GAD in infarct size as a volume fraction of the LV, and in quantifying the average transmurality of the infarcted segments for each patient. So as proof of principle validation, we also tested the VNE in a pig model of chronic infarction with CMR and histopathology data from our collaborator Rohan Dhamma-Kumar when he was in UCLA. So VNE revealed a clear LAD infarction in these 2 test cases in high agreement with ex vivo slices and histological staining. So VNE was named as a landmark technical innovation in the history of CMR development by the editors in Circulation. And this is a great opportunity, and we're working on validating it for other common pathologies and clinical applications. And so over the past decade, we have contributed to 2 of the major CMR developments, both by pioneering our shortened T1 mapping technique in 2010 and now VNE in 2020. And so to test the VNE technology in real-world clinical workflow, Chang, our computer scientist, has implemented the deep learning models into a pipeline to produce VNE images on the fly during scanning. So here is our first test in our scanner on a patient who was referred for viability assessment. We took the pre-contrast Cine images and the native T1 maps as soon as they were acquired, and before injecting gadolinium contrast, produced the VNE images while the patient was still in the scanner. And so here, the VNE images show a clear infarct scar in the anterior wall and the anterior septum. And then these were confirmed on the real late GAD images when they did come. And in this patient, the VNE showed high agreement with late GAD in the location and the extent of the infarction. And you can see here on the late GAD where the yellow arrows are pointing, they are breathing artifacts on late GAD because the patient was getting tired by the end of the scan. Late GAD has to be acquired at the end. And in comparison, VNE overall has better image quality, partly because it is acquired very early on when the patient first goes into the scanner. They don't have to wait all the way to the end of the scan to do those images. And so now we are working on stress T1 mapping, and we can combine stress T1 mapping for ischemia testing and this virtual late GAD technology for renal failure patients. As you may know, traditionally, renal failure patients have been excluded to benefit from CMR because of the risk of nephrogenic systemic fibrosis. But now we actually have technologies to produce a gadolinium-free scan for them. And, instead of taking 45 minutes to an hour, potentially you can do Cine, rest, stress T1 maps, within 20 minutes, and you can get the virtual late GAD off of those, and the patient doesn't have to stay there for a long time. So we have completed a preliminary study of 35 renal transplant candidates with virtual late GAD together with stress T1 data, and we will assess the potential cost effectiveness and savings from this approach. And so the parametric mapping is already widely used in many CMR centers worldwide, and beyond Cine and late GAD, mapping have been shown to aid advanced tissue characterization in a number of studies over the past decade, and they may be especially useful in the following. So detecting changes in edema, inflammation, such as in acute myocardial injury or myocarditis, differentiation of LVH phenotypes, such as hypertensive heart disease, HOCM, amyloidosis, Fabry's, and athlete's heart, non-ischemic heart failure, without infarction, without coronary disease, and assessment of iron overload. And these MR signals like T1 and T2, they correlate to histopathology in a range of diseases, including the presence of acute myocardial necrosis and focal fibrosis, edema and inflammation, and also expanded interstitial space, whether due to amyloid, infiltration, or interstitial fibrosis. But we need to remember that these MR signals, they're not specific. We always need to interpret them within the clinical context of the patient. And excitingly, we can now use mapping to create virtual late GAD images using AI and machine learning. And so this is the parametric section, but I wanted to just briefly talk about the other tools of CMR that we can use to investigate cardiac diseases. So cardiac MR fingerprinting is a powerful tool to measure multiple tissue properties in the myocardium simultaneously. So you can allow a seamless investigation of an array of diseases. So you can do T1, T2, ECV, T2 star and fat fraction like in one go. So a lot of people are working on MR fingerprinting. These are new stress perfusion blood flow maps. They're currently not yet a clinical product, but they are available as work in progress packages that you can get on some clinical CMR scanners. So on the left here is a healthy volunteer showing significant augmentation of their myocardial blood flow at peak vasodilatory stress compared to rest. And on the right here is a patient with triple vessel coronary artery disease showing very impaired blood flow in all 3 coronary territories. And these are immediately available on the scanner as you scan. So there's no need for cumbersome image post-processing. And here is an example of a patient with microvascular angina, no obstructive coronary disease. And what you see on these perfusion maps is a circumferential subendocardial impairment in the myocardial blood flow as compared to this subepicardial half of their myocardium. So this is sort of a signature of microvascular dysfunction. This is another example of microvascular dysfunction at apical hokum. As you can see here, again, this subendocardial ring of low blood flow during vasodilatory stress as compared to the epicardial half of the myocardium. And so one of the novel imaging biomarkers to characterize myocardial fiber structure is diffuser tensor imaging. It allows us to map the magnitude and direction of water diffusion along myocardial fibers, and it can provide microscopic details of the myocardial architecture, and it can be especially useful in the study of myocardial disarray, such as in HOCM. So 4D flow, Julio Garcia in your center, works on this, and he leads the largest 4D flow program in Canada, I'm told. And so it can assess parameters such as aortic wall shear stress, pulse wave velocity, and the amount of helical, rotational, and turbulent flow. You can use 4D flow to assess valvular heart disease, especially the aortic valve. I know Paul Fedak works very closely with Julio and the Stevenson CMR Center. And you can look at the blood flow pattern and wall shear stress that are associated with aortic dilatation. And here's a nice review by Julio on 4D flow patterns and quantification in aortic stenosis and associated aortopathy. We can also use 3D flow mapping to quantify intracardiac kinetic energy, flow volumes, and assessment of ventricular efficiency. And this may be useful in characterizing heart failure and congenital heart disease, such as for conduit assessments. And by now, we have all heard how AI can be applied in healthcare. And for CMR, AI can definitely be used across the entire CMR workflow, from image acquisition, signal reconstruction, image quality assessment, analysis, quantitation, classification, and reporting. So this is one of the editorials from Radiology just earlier this year, essentially, outlining what the up and coming techniques are that are very close to being available or are already available clinically. So CMR acceleration strategies are going to be one of the major topics for technological development. We've talked about parametric mapping, 4D flow, and quantitative perfusion mapping. And of course, AI, can produce a lot of new things that previously are not possible. So this is exciting times. And in terms of future directions, I believe that these are the three main pillars that underpin a leading CMR program. So this includes research and innovation, which drives advancement of the technology, and also clinical excellence. But this is always informed by clinical needs of the physicians and the patients who use this technology. We need to continue to educate and train the next generation of practitioners and researchers, and also physicians who use this service. These components are dynamically informing each other in a bidirectional manner, so there's always progressive cycle of improvement in each pillar. And in terms of research and innovation, I see plenty of exciting opportunities here in Calgary. They can be broadly categorized into the CMR arena, such as technical innovation and clinical applications, and also collaboration with other cardiology, imaging modalities. And in terms of applications, within the cardiology subspecialties, many will have crossroads with CMR where we can contribute, and even other medical specialties like immunology, oncology, rheumatology, and nephrology now. And I am excited, that you have a precision medicine initiative. It's led by James White in the Libin Cardiovascular Institute, where we can apply many of these tools. So that brings us, to a final, but, this is important, is education and training of the next generation. So these are my two most recent DPhil students, the PhD students at their graduation. This is at the Sheldonian Theater where awards are conferred. So this is just earlier this month. And both of them have moved on, to lead their own programs. So Mayuran is the clinical lead for heart failure in one of the hospitals in the UK. And Matt is a cardiologist in Australia, and he's just won a major grant using VNER technology and cardiac amyloidosis. And so now this, usually you can't go into, but I'm going to bring you inside the Sheldonian Theater for a very short clip of the graduation. These are the PhDs. So they're brought down. And so here is the vice chancellor in the middle, the senior proctor on the right, and the junior proctor on the left. So this lady here is Green Templeton College's warden, the principal, and she's going to lead and present the graduands to the proctors and the vice chancellor. They are speaking in Latin. I don't think you can maybe hear them, but it's all conducted in Latin. And so, they have to bow to, when they're speaking, at the graduands at the moment. And so they will take out their cap and then you need to bow to them. So a lot of interesting rituals there. And so, afterwards, they are then introduced, out, of this process. And then they will go outside and they will change into their gowns and they will get represented, to everybody. And so then, then they're going to walk off very soon. And then I have the next clip. So they are now coming back in. So they've changed into their very colorful gowns now. And this is the moment, where everybody is happy. So you stop them and you get a bow. So that's so right. So acknowledgement, all the colleagues, from University of Calgary, from when I was here, I have very fond memories of Calgary, but, there are key individuals who really helped me, with my journey. Lisa Welikovich, she was program director. She offered me the position to be a fellow here. So I am eternally grateful for that opportunity. Dr. Kavanagh, who was my research advisor from the very beginning and, gave me lots of very good advice. Todd Anderson, who helped me with the application with the Alberta Heritage. And of course, Matthias Friedrich, who was director of the CMR Center at the time. We continue to work together internationally. And so, of course, everybody else, who worked together, this is, work that was done by many people all together. So I thank all of them and of course the funders who made this possible. So thank you very much.
Much, Vanessa, for that wonderful talk. So, we will open the mics. Go, and we'll open the chat. So if people online would like to put questions in the chat, that would be great, or they can just kind of speak up on the mic. Maybe we'll start with the room. Are there any questions in the room?
Thank you for the great presentation. I have a question about the LGE, the AI mapping. So knowing that T1 can generate such a diverse amount of data, isn't it easier if you just generate, identify, be able to diagnose from the T1 map directly instead of converting to LGE map before going to a meta-analysis?
Yeah, that's a really good question. So let me repeat that for the online people. Okay. So there's a great question from the audience. The question is, because T1 mapping can detect so many different disease processes, why don't we just read off the T1 map rather than create a late GAD lookalike? So this is a very important question. So this is one display. So there were two motivations for this. Number one was that the current T1 maps, we haven't develop a good way to visualize, the changes in them, because late GAD is quite easy for clinicians. It's black and white, scar is white, and, normal is black. So it's easy for us to immediately visually diagnose something. And it's not the same at the moment, for the T1 map, because you would have to do post-processing and you do thresholding and show where the patterns are, where is it abnormal. So that's one thing. And the color maps that I show you, they are pretty, but they're not meant to, give you immediate visual diagnostics. So we're still working on display of the T1 map, and in particular, the pathology, that is supposed to pop out to your eyes. Secondly, late GAD, because it's familiar, we thought this is one presentation method we can present, the findings to the clinician. And of course, the gadolinium-free concept is quite easily understood, by people. But you're right, because T1 mapping is beyond late gadolinium enhancement. We shouldn't sort of limit it to, let's make it look like, late GAD, because it can detect things beyond late GAD. That's absolutely right. Oh, yeah, okay. So there's a question. What is your opinion regarding CMR versus, is this nuclear, like MPI is nuclear for myocardial viability? So back in 1999 and 2000, when late GAD, CMR late GAD was first developed and validated, there are pathology papers out there. So for nuclear, it can definitely detect the transmural MIs, CMR, and nuclear, they can do that. But it's just a small subendocardial MIs that sometimes are missed on nuclear imaging that CMR can detect. And as a result, CMR is the imaging gold standard for viability. What are the current limitations of VNE imaging? How sensitive is it to the imaging parameters? Yeah, great question. So current limitations of VNE is we are currently training the neural networks by disease model to begin with. So we've done it for HOCM and then chronic infarction, and we're working on cardiac amyloid. And so the current limitations are that we haven't done all comers, like, let's say, because the patient is not going to tell you, oh, hey, I have HOCM, what is it? So it needs to be able to deal with any pathology. So that's one limitation. We need to work on that. It needs time. Secondly, acute pathologies can sometimes confuse the neural networks. So because acute MI or acute myocarditis, it will have really high T1 values, but there's no late GAD sometimes. Like it might just be a lot of swelling, and it can confuse the neural network to think that there is a scar when there isn't. And so now, we have not encountered that in the chronic MI model because we did not choose acute MI, data to put in there. But that is one thing that it can confuse the neural network. So basic concept is the neural networks are kind of like medical students, or even like, maybe, they're students. And so you need to give them lots and lots of examples for them to learn it, to remember it, and then deal with unseen data. How sensitive is it to imaging parameters? It is important to make sure that your image quality is good. So the T1 map has to have very good image quality. And we have quality control measures to make sure that, this T1 map is actually good before you feed it to train, the neural networks, or before you use it for diagnosis. So in AI and machine learning, QA, QC, quality control, quality assurance are very important, especially when it comes to medical imaging, because you don't want to use a bad image to diagnose somebody. And so we work on a lot of QC, QA methods as well behind all of this.
I have more specific question about VNE. How is it behaving in areas of vascular obstruction and IV degeneration as well?
Yeah, so question is, for VNE, how does it behave in microvascular obstruction? So that's seen in acute STEMIs, usually like a large acute MI, and also chronic scar, where the fat may have started to, infiltrate the or the fat, the scar has changed into fat. So those are very important because we've done the validation and the paper in chronic MI. We're now going to do it in acute MI where it has all these other pathologies like MVO and also a lot of edema. There may be intramyocardial hemorrhage within the MVO as well. So there are multiple coexisting pathologies that can either drive down or drive up the T1 values, and they are not necessarily all in the same direction. So we need a lot of data to train the neural networks, and we have that data because Oxford has the acute MI registry. So we will work on that one. And the second thing is chronic MI, where fat, because the scar, depending on the age of the scar, it can have high T1 values, pseudo-normalized T1 values, or low T1 values. And it depends on when you image them. And so if the machine thinks that, oh, scar is high T1 all the time, it might not be able to deal with pseudo-normalized T1 or low T1 scar. So again, data is important. We need lots of data and variety to train it. Yeah. Steve.
Thanks. Wonderful talk. And just wondering if there's been any work looking at atrial tissue in some of these.
Yeah, so I have I had a previous PhD student. He's an EP specialist. He works on AF, and he tried to scan all the patients in AF. That was his entire PhD, is to scan patients in AF. It was very difficult. So he was looking at atrial mapping. The issue is that the resolution, because the atrial wall is so thin, and our voxel size, let's say the Schmoly one, when it's interpolated, the in-plane resolution is sub-millimeter, is 0.9 by 0.9, but the slice thickness is 8. You could bring it down to 4, like we tried to bring it down to, but you can see the issues with that because you're going to include, partial volume from tissues behind and above the slice. So it doesn't mean that you can't, sample that area, but I think it would be a little bit noisy. Yeah. I think Dr. Wu, and there's another, I think you were,
Great talk. So the perfusion imaging, I think, is interesting. Do you know how well CMR stress flows correlate with like PET stress flows?
I think that, now I haven't done that research, but I believe they have, cross compared, those parameters, and they compare closely, with the blood flow. Yeah. And of course, CMR is more widely available. The PET requires the cycle. Do you have PET here? Do you have PET in? Yeah. Okay. All right. Yeah. Great. Yeah, but that's a good question. Yeah.
I have a question. Whether gadolinium concentration of TI value, T1 value, if it does, I guess it is. So in reality, the body weight we input is from the patient report. If it affects the T1 value, weigh the patients before we. All this impact on the clinical diagnosis.
So we don't use post-contrast T1 by itself for diagnosis. We use native T1 maps, so the gadolinium would not be affecting the T1 values if you do pre-contrast or native T1 values. So in our center, we don't use post-contrast T1 to diagnose disease. And also, it's exactly what you're saying. So many things can affect the post-contrast T1 map that the consensus statement, the FSCMR consensus statement, does not recommend the isolated post-contrast T1 map, for use. The preferred outputs from T1 map is the native T1 map and the ECV, because ECV can, somewhat account for some of those factors that affect, gadolinium kinetics in the patient. So, so that's why we don't use just the post-contrast T1 map, because it could be affected. Yeah. Oh, yeah. Okay. Can CMR detect coronary's calcium score? Unfortunately, CT wins here. You're going to have to admit defeat here. So CMR can do coronary angiography. People like Warren Manning in Harvard, Beth Israel, and also Rene Bontner, he was at KCL. They worked on a lot of MR coronary angiography, and some of them are very good, but subject to the usual limitations of CMR. But for calcium, because calcium just looks like really dark on the CMR, it would be a signal void on CMR because calcium doesn't have. So for calcium scoring, you're going to go with CT.
Other questions?
lovely talk on beautiful images of tissue characteristics, I guess, and sort of static images, but have there been some advances in terms of dynamic imaging of LV contractile properties, dyssynchrony I'm thinking of, or maybe predicting LV pacing sites, those sorts of things for heart?
Yeah, and you just repeat that for the online. So question is whether, so static T1 mapping images are beautiful. Are there efforts to do dynamic mapping combined with, let's say, wall motion, contractility, for, pacing and EP indications? Yes, I know people are working on it, definitely. I'm not working on it, but I know people are, working on combining, let's say, MR fingerprinting, multiple parametric tissue characterization in combination with wall motion or strain, things like that. Yeah.
Well, I think we'll give you a rest there.
Okay.
Vanessa.